Okay, well, I will kick off, Kerry, and just do our customary acknowledgement of country and acknowledge the traditional owners of the lands on which we are all meeting here tonight and today. And here I'm meeting on the Wurundjeri lands in the Kulin Nation. And I pay my respects to elders past and present. Encourage you to share where you're joining from too in the chat tonight as well. So thank you all for coming along this evening, and thank you to Professor Dame Till Wykes for joining us. And it's one of our inaugural events for the National Centre. For those who may not know me, I'm the Director of our National Mental Health Research Translation Centre here in Australia and in Melbourne. We have 15 university partners, a lot of collaborations across different sectors, and we've been in the landscape since April this year, and we're just in those establishment phases, and we're very much looking forward to how we're co-designing our roadmap to help guide mental health research translation, and we're looking forward to learning from the lessons that Till is going to share with us tonight. We're very, very delighted to have you here. And so I'm going to hand over to one of our co-chairs from the Intersectoral Policy and Practice Committee, a very important committee for the Centre, where we try to foster relationships with non-health sectors and think about the social determinants of health and all of the intersecting issues with mental health and how we can improve care in Australia. So thank you everyone for joining, and I'll hand over to you, Kerry, and I'm looking forward to your talk, Till, and we'll join you after. Thank you.
Thanks very much. And I'd also just like to recognise and centre those attending tonight with lived experience, either personal lived experience of distress or families supporting them. I'm delighted to welcome and introduce Dame Till Wykes. Like many of you, I'm sure, I've been following her work as an ally and a leader in centering lived experience understandings of distress in research in the UK. So Till is the Professor of Clinical Psychology and Rehabilitation and Head of the School of Mental Health and Psychological Sciences at King's. Her research has been varied, with explorations in cognitive science, developing treatments and evaluations of those treatments, and mostly for people with a clinically attributed diagnosis of schizophrenia. She's committed to involving people with lived experience in developing studies and the questions to be asked. She founded the Service User Research Enterprise, which is again a bit of a North Star for those of us in Australia who have been following the evolving work done at that centre, and obviously followed much of the work of Diana Rose as well, which employs research experts in research who have also had experiences of using mental health services. She's also the editor of the Journal of Mental Health, holder of a Guinness World Record for the largest mental health lesson. I think that bears repeating. And here's another word that bears repeating: and the Queen bestowed a damehood, which is a knighthood for women, for her work in mental health research. There's a word I've been waiting all day to say, a damehood. Her overview of her talk tonight is around, I should point out it's actually quite early morning for Till. She'll be covering mental health research priorities, which are usually set by, as we know too well, national funders, with usually little integration of the views of scientists or people who will benefit from or even have an interest in setting the agenda of research outputs. This talk will explore a few ways of developing priorities and describe two exercises that I've been following very closely that have produced the European and UK goals for funding over the next 20 years. And hopefully we can have some discussion around what this might mean for our centre and the roadmap and so on, and the importance of doing these exercises. So without any further from me, I will hand it straight now over to Dame Till and ask her to give us her presentation. Thank you very much.
Okay, well, thanks very much for inviting me. I'm going to talk about why, how, and what we should be studying. As Kerry said, I've got a couple of examples of what we've done in the EU and in the UK. If any of you actually saw me pre-pandemic, some of these slides may be very similar, so this is revision. because what I wanted to do when I came over before was to try and extract some of the information from the draft Commission productivity report. But I'm also going to tell you about ways in which things have changed around the world. So first off, always have to produce my disclosures, if I can work out how to move my, sorry, I think there, okay. You know, a year and a half on Zoom, Microsoft Teams, Google Meetings still hasn't taught me all of to look at, well, I've currently got 3 screens at the moment. So these are my disclosures. I'm not going to talk about circuits, so you don't have to think of me as a second-hand car salesman this time. So the talk is about, generally about, the aims of the talk are about 3 words. One of them is strategy. The other is about priorities. And the final bit is about goals. And the reason that we're talking about these is because often people think of these things as all being the same. They're not all the same. Strategy is often about how you spend money. Priorities, and I've chosen priorities changed, is that you need to have some way of thinking about a mental health strategy for investment, which can adapt to, you know, information which we gain. And we need to think about how we achieve our goals. What are the goals of mental health research? So how are these research strategies actually set? Well, they can be by the government, by funders themselves who decide how they want to put in the money. Often that's by, you know, 5 people sitting on a committee. It's sometimes by scientists because of the way that they think about pushing funders, and very occasionally, and I tell you it is only very occasionally, by the public. But the public are important. I mean, for cancer research, there was a lot less research on the ways in which breast cancer was treated. But that all changed when women with breast cancer actually stood up and said, we want more information about these different kinds of treatments. So they do have an effect. But I'm going to just talk about, first of all, the government and how governments set research strategies. Unfortunately, sometimes this is by chance. It is by a minister bumping into a few people who impress him in terms of what they think ought to be investigated. And sometimes that actually is not the best way to set strategy. But this is the EMBO report. So it talks about the economic costs of mental disorders. It followed up an earlier report saying more or less the same thing. Their conclusion was that mental disorders account for more economic costs than chronic somatic diseases such as cancer or diabetes, and their costs are expected to increase exponentially in the next 15 years. And one of the reasons why this is important is that governments, particularly finance ministers, listen to the cash. So the estimate of the worldwide lost economic growth is 16.3 trillion. And I can't remember whether that's euros, dollars, or pounds, but I think it's probably dollars. So it's an awful lot of money that's lost in the world. And if you want to get a finance minister's attention, you give them this sort of data. So you have that data, actually. It comes from now the published report that 1 in 5 Australians experience mental health problems each year. Now, I must tell you, is own up, I tried to look for some of the data that had changed, and some of it definitely had changed between the draft report and the final report. But originally I built my slides on the draft. So I've tried my best to find the numbers. but occasionally I may get it slightly wrong. But I've set this up so that you know that it isn't just worldwide that there's an effect on the economy. There's a very high cost to the economy in Australia as well as around the world. So in particular, there's 150 billion that's lost for reduced life expectancy and early mortality. And it's this cost to the economy, which is really important to finance ministers. And that results from things like presenteeism and absenteeism. So presenteeism is when people with a mental health difficulty go to work but can't give it their all. And absenteeism, of course, is when it's very serious and they just can't face going to work. And that has an effect on compensation claims. So here, this is the total compensation, which has remained constant, whereas the mental health stress claims has actually increased over time. And this mirrors exactly the data that I managed to get for Germany and for the UK. It used to be back pain that was very high, and now mental stress has actually overcome that and is now, has been increasing over time. And clearly, the pandemic has emphasized problems of mental health difficulties. It isn't that at least in the UK, the number of suicides has not gone up. People have started to talk about mental health difficulties, and governments, because people have talked about mental health problems, particularly in the young and from issues like loneliness in the elderly during that lockdown period, that they've started to pay attention to what resources there are to support those services. And of course, that highlights, well, what the heck are we going to provide in those services, and what should be the organisation of those services? Well, you can tell them that for each £1 invested in mental health research, that for cardiovascular disease, the return is about 39 pence a year. For mental health, the research is 37 pence. So after 3 years, you're really making a profit on the money that you've invested. And in fact, recently, Public Health England, which is a body in the UK, has estimated that for some studies, actually the return for each year in perpetuity for £1 spent is about £5, anything between £2 and £5 in terms of developing interventions for services. So it is important to tell governments that there's not only a problem that they have to deal with that will affect the economy, but also that mental health research actually provides a good return on investment. So these are all good reasons why government should actually invest in mental health research, but do they actually invest? Well, these are the same people who brought to governments information on how they should be spending money. And as you can see, the DALYs, which is the disability associated life years, so the disabilities associated with mental health, which of course have implications for the economy, and particularly because mental health difficulties start early, whereas of course cardiac problems, which also affect the DALYs, the disability associated life years, actually usually start much later and therefore have less effect on the economy. So here you can see in, I don't know what it looks like on your screen, but a sort of reddish brown is the DALYs. And that's all much, much higher in 4 countries in Europe than not only the healthcare expenditure, but actually in blue, the research money that is invested. More recently, there's been a look at how that money is being spent as well. So this is global funding for mental health research by diagnosis. As you can see, substance use and dependence is very high. There's good reason for that, of course, because of the problems. The biggest funder, of course, in the world is in the US, NIMH, and the substance use and dependence in NIH, because of the opioid dependency issues. But depression comes next, and autism. But some of the things which are really important, like the ones that I've emphasized here, ADHD, eating disorders and conduct disorders, as well as self-harm, have incredibly small amounts of funding across the globe. So there are some things which seem to be getting attention in terms of the resources attributed to it, but not actually some things which seem to be missing, and probably particularly for ADHD, eating disorders and conduct disorders, which are generally issues dealt with that arise early. These things are getting very little amounts of money, and yet they will predict a lot of the disability associated life years later. So from this same study, it looked at the translational pipeline, so where the funding was actually going to, so whether it's for treatment development or prevention. And as you can see, a lot of it is spent on where these problems come from. So the development of problems. But actually, so here, that's where the money is. There's still quite a lot of money on underpinning research as well. But doing something about the mental health problems, there's very little of that area. Of course, the other thing that this particular study highlighted was the bias that there is in where that money goes for mental health research, the majority of it being, of course, in developed nations and not in, for instance, in Africa or India or some parts of Asia. So looking at Australia, these are data that Phil Batterham gave me. So the proportion in terms of illness burden, I think this must be the sort of DANIs. Again, the problem in Australia is that there's a lot less money spent on research than there is compared to the level of illness burden. Now, I always have to, I always feel guilty making these arguments because, of course, different kinds of research cost different amounts of money. So it's very difficult to make comparisons completely between the kinds of research maybe that costs a lot, like potentially in cancer or asthma or arthritis, compared to mental health. What I'm really giving you is an argument about why money should be spent, and the very simple argument to provide to any governments about how they're under supporting mental health research. Okay, so you're thinking about how to make a roadmap for mental health research, which is great. I think it's really important because it focuses our attention. But others have tried this, and one of them is actually the NIMH. So NIMH produced some global challenges in mental health, which were supposed to force us to consider how we should spend research money in the future. So they produced this paper in Nature, and the way they did it was to look across the world, but I wanted to emphasize two things. One of them is the method. They used a Delphi method, and the other is that they had 422 participants in the study, which means that they had 60 countries, so they only had on average 7 people from each country taking part in this research. And my suspicion is there were a lot of people in the US and UK because the key authors were from the US and UK, and not very many from other organizations around the world. So I'm not using this as an example of how you should do it, but this was an early way of managing it. There's another one which was carried out by the World Health Organization, and what they did was just to contact the countries involved and asking them what they thought, which didn't involve many people at all. And although this 422 participants here includes researchers, advocates, program implementers, and clinicians, I happen to know, because I was part of this, that actually I think I filled 3 of those positions. So it isn't actually that they had that many people in each of those categories. So I want to come on and explain what ROMA is. ROMA was a roadmap for mental health research in Europe. Unfortunately now, of course, the UK is not part of Europe, in fact, I had a big research program that was launched the week of the referendum, and we of course told everybody, don't worry about this, we're never going to leave the EU, and then of course we did. But the money for the Roma program comes specifically from a public health fund, and that affects how we approached the work. So we didn't include laboratory research in the Roma work. So one of the things that we did was to think about 2 separate boxes of things. So we thought about public health interventions for promoting mental health and well-being, because that was where the money came from, and also had as a priority new, safe and effective treatments and services and social interventions. And we sold it because we wanted to reduce burden on society. So those are the indirect costs to society for mental health difficulties. And we wanted to reduce treatment costs, so the healthcare costs, which are the direct treatment costs. But we also took into account the competitiveness of Europe. So what were we good at? And that's really important when we're doing research, because you do not want to do something which somebody else can do really well. So the Roma program looked at 28,000 and change papers. We mapped our expertise across Europe. We looked at knowledge gaps, but also bearing in mind what we were pretty good at. In Scandinavia, they're pretty good at epidemiology and some genetic studies. And we contacted 1,000, well, this is an underestimate because we actually contacted 1,000 organizations and individuals. But what I wanted to let you know is we included this group of people, which was not included in the NIMH group. So we looked at service users, families, and their organizations. And when we were making decisions about the final priorities that we could consider, we did have a survey and we prioritized the views. In fact, the top 10 was the same between between the scientists, clinicians, professional organizations, and throughout. However, we prioritized the top 6, and that was affected by what service users, families, and their organizations wanted. So the way we did all of this to get to 6 is we had work packages. Each work package produced its own list of priorities, taking into account what we know, the knowledge gaps, and we had common criteria for deciding whether something was feasible to do, whether it would have a result would have an impact over the next 5 to 10 years. And they use those same common criteria to justify there are 150 priorities, which is clearly far too many. So we went through, and in fact that was my job to go through with my research group and integrate those priorities amongst each other, because there was overlap. And then we had this prioritization survey. And as I said, the prioritization survey at that point produced then 6 high-level priorities. I'll just show you how we integrated them. So this is, you don't have to read this. These came from different areas. We thought they overlapped quite a lot. We reduced it once, and then we reduced it again to produce this. So research into preventive measures and resilience as part of a wider focus on positive mental health and well-being. We never threw away a single priority, because that's part of negotiating with each of the work packages in the Roma project. They're all kept in an appendix. So the groups and so researchers in particular can always refer to, this was a priority produced by the Roma group, and they can refer to the exact priority and the wording of it in the outcome. So after this, my next job, I think, is world peace, because this was a very, very difficult task, particularly as scientists kept saying, well, where's mine? Where is my wording? Where is my priority? i.e., where's the priority for my own personal research? So you do have to rise above it. And one of the things that we could always point to is the fact that we ended up with priorities in our appendix. So if you want to read it, there's a paper which is 7 pages long, and there's 194 pages that's held on the web. So I want to just tell you a bit about the headlines. So one of them was the one I've already shown you, but it also includes, we emphasize children, adolescents, and young adults. We decided to look at causal mechanisms. That is partly to do with the etiology issues, but also we wanted to add well-being, so concentrate on positive outcomes as well. A really important one was actually about the sharing of research. So Europe is a very big place, and it has underlying positive things which will help our research, because healthcare systems are different. There's different cultures, and there's also different data that we could use to share in order to put together a database where you could really extract important information, not just for a single country or a single local geography, but actually measure things across over groups. And we wanted to try and build and maintain those international and interdisciplinary research networks across countries. We wanted to have better interventions, and that meant also using new scientific and technological advances. And I can't remember whether I've put one in, but prevention is quite important. So here we've got the investment with €1. So if you invest €1 for early screening, you get €10 back. If you invest it in prevention measures, you get about €18 back. And for mental health promotion, you probably get about €84 back. So there's a reason why this investment is really important for prevention. But also, if we're using new scientific methods, might think about using polygenic risk scores. This is an early study which definitely needs replicating, everybody says. But this is a study involving individual, group or guided self-help for children who have anxiety disorders. It's a study run by Kathy Creswell. As you can see, there's very little difference at if they calculated the polygenic risk score in low and medium groups, there's really not much difference between the three groups in terms of the outcomes that they have. They're similar. It's only when you get to the high risk group that you can see that actually you may need to provide the most significant, so this one, the most important way of reducing anxiety in these children and young people is to provide individual CBT. And that actually, if you provide guided self-help, that doesn't produce any effect whatsoever. So they really do need some more intensive therapy. So that would tell us how to attribute treatment, and particularly that we might need to provide more individual CBT for those with the polygenic risk, high polygenic risk score. Oh, my blessed phone is going. I'm hoping my husband is in and I can answer. I'm no way I know of turning that off. I'm actually giving this talk in my husband's room, so and he's not here. So anyway, I won't get thrown again. So the 6 headlines also include 2 more, which is about reducing stigma and addressing the quality of care. These are very important issues for our for research and for our service users, because what they've said a lot is about, it's okay to provide services, but we don't know how good they are, and particularly doesn't give us most of the services are all the same and don't take into account socio-cultural and socio-economic context. And of course, if you're going to provide mental health care across Europe, you need to take those cultural differences into account. So moving on to service user involvement, which I've sort of mentioned already, we need to think about how best to involve service users. And this has a history. It's not that we just invented it. There is something called the Database of Uncertainties, the James Lind Alliance. These are priority setting partnerships which bring patients and clinicians together to identify uncertainties. It isn't that they have, they're good things. I'm not suggesting they're not good things, but some of the service users do complain, or people with lived experience. I just say, I always use service users because that's what the service user research enterprise adopted, and that's what the people with lived experience chose. So, but the reason I put patients in here is because this is a direct quote from the website, because it doesn't just include mental health service users, it also includes people with arthritis or cancer, etc. What some of the service users have said is that it's quite hard to actually feel like there's an equality of power in this process, and that is a problem. But they do produce a consensus agreement of the top 10 list of uncertainties. And they do that by producing a systematic review, asking people what their priorities are, usually by surveys, and then comparing and contrasting them with the systematic review of what research is either underway now or the question has already been answered. So they produced a set of research priorities, but they concentrate mainly on diagnostic groups. So they have one on schizophrenia, which was one of the earliest ones on mental health. They've got one on depression, which where they worked with MQ. And there is one which adopted those JLA methods, which is from McPin, which is a service user research organization. So as you can see, the McPin one is about children and young people's mental health. And there's another one much more recently, which is about the research priorities for digital technology. And there's actually a further one going on, I know, which is looking at digital technology for children and young people. So let's think about how Australia should be thinking about priorities. Well, the first thing to say is that you just have fantastic data. I am incredibly impressed by the background document, which has a lot of information, only a little bit I touched on, but it will definitely be my go-to place for evidence. You've got really interesting, you've pulled together really interesting things, and I just thought I'd look at a couple of areas. So this is about students falling behind because they have mental health issues. And we now know, at least I think it's in the Australian data, but it's also now in the UK data, that kids with mental health difficulties have problems in school attendance. So they attend far less, and that obviously has an effect on their educational achievements. But as you can see, that students with mental health difficulties that continue just have reducing levels of educational achievements. The other thing that we know, and this is a really hard, although the one thing I would complain about is the use of the words female and male. I always think that, you know, when you use those sorts of words, you're not really talking about people, you're talking about things with fur and tails. But women with a mental illness here, it's looking at the share of comorbidity issues when you have a mental health problem. And as you can see, circulatory diseases, which are a lot to do with coronary heart disease, people with a mental illness have those in spades here. And we do know from information across the world, actually, that if you develop a symptom, not a diagnosis, but for every symptom of depression that you develop, the chances of a heart attack increases by about 16%. We also know that people with rheumatoid arthritis who develop a foot ulcer and have depression have a much higher chance of dying within the next 18 months than those who do not develop depression. So comorbid disorders are really important to look at because there is an effect on the cost of treatment, particularly an effect on treatment costs in the healthcare services, so those direct costs, but also have massive effects on mortality. And we know for those people who have serious mental health problems that the loss of life years lived is up to 20 years. So it's about 17 to 20 years. So how should I suggest that you develop a research strategy? Well, clearly you need to involve the people who are giving you the money to do the research. So you need to involve the funders. You need to involve academic researchers because they're the people who will know what's likely to go on in the future. If you're going to get questions asked which are important to healthcare services, you need healthcare professionals. You also need professional bodies because they are important to understand where you're going. You need charities and you need service users and carers. So a good research strategy would involve all of these groups of people. But what methods should you adopt? There are lots of different ways of doing it. You can use Delphi like they did in the NIMH study. You can do surveys, you can do public surveys, you can have citizens' juries. Citizens' juries is the one that so far we haven't really adopted, or I haven't really adopted in any of the methods. You can involve all of them. But I think what's important is also this, making an impact. For the Roma project, we coordinated an effort of launching this to bring it to the attention of the public everywhere. So we had a day's press release, and we had meetings with the press to try and get it out. And we managed to get a lot of information out. So from the BBC right the way through German, French, Spanish and Italian. And not only did we have that impact, but you need to have an impact on funding. And these are the things that immediately followed the Roma project. So we got more money into personalized medicine, into e-mental health, and into the Global Alliance for Chronic Diseases, actually added mental health to the list of chronic diseases which were important. In the UK, we had something called the 5-year forward view. And I was involved in working on that. And we got mental health research priorities. The sentence is mental health research should follow the roadmap set out in the Roma project. And it also recommended that a 10-year strategy for mental health research that they would publish separately the next year. And that's what they did. So they produced a framework for mental health research, saying a bit more about how it should be funded. We got the Medical Research Council produced a strategy, and MQ, which is a charity supporting mental health research, also produced a strategy soon after. But you really want to make a real impact. And the real impact is making sure you've got the investment. And a real impact is on people themselves and on mental health in the population. One of the things, there was a paper produced by RAND Europe saying that one of the things which led to real impact was bearing in mind what effect your research should have. So for even basic researchers, so people who are working in laboratories and not really working with people, if the researcher bore in mind what the ultimate goal was, then they were more likely to have an impact over the next 15 years than people who didn't bear that in mind. So I'm now moving on to what the heck is your goal in terms of mental health research? You need a limited number of goals because nobody can concentrate on 150 like I had, or priorities. You need to have them accepted by everybody. You need to measure them, because you may need to change those priorities, as I had at the beginning of this talk. You need to describe the research that's needed to complete the goal, and you need to adapt the targets when evidence is available, because you need to be able to be flexible and switch funding to different kinds of research. Quite often that doesn't happen, and it's a very slow thing. So it only usually happens every 10 years, whereas, you might have discovered something in 3, in which case, why continue to fund or to just reinvent the wheel, which is what sometimes happens. So with 2 important people, Peter Jones and Kathy Creswell, but we had the idea to produce goals, but actually the key person in this was Chris Whitty. You may not know who he is, but he's like a rock star in in the UK because of his appearances during the pandemic. What he did was bring us together and guide us through the process of producing goals. He is the Chief Medical Officer for the UK, and he was the head of the National Institute for Health Research. So an important person, held 2 jobs. And then, of course, we were about to launch our goals in January 2020. And the meeting we had set up to work out the press releases was the first day of what was called the COBRA meeting. The COBRA meeting is the meeting which decided which recognized the very first intimations of the pandemic. So we did get a little derailed by that. So we involved health service providers, research funders, charities, service user groups, and individuals, so service users and academics, to produce this document. We'd already got, information from the various James Lind Alliance work. This is a UK focused project. We had information from Roma, but what we wanted was actually to develop goals, not what research should be carried out, but goals. So I'm going to tell you all of them, but I want to give you this one first. So the goal was to research to halve the number of children and young people experiencing persistent mental health problems. And I can't really describe how many meetings we had to define every single word of this particular goal. So some people wanted to get rid of any mental health difficulties experienced by children and young people. Some people said halving the number was too hard a target to get to, so we should change it and make it 10%. Other people said we shouldn't be using the word persistent mental health problems. But in the end, there was enough goodwill amongst the groups to come to this particular goal. It's a goal which is stretched. We decided it had to be persistent mental health problems because we know that young people do have periods where they feel great sadness and may even verge on a diagnosis of depression. But what we were trying to do was to prevent those mental health problems being experienced in adulthood. So we went with that. We attached targets. So the targets describe more the kinds of research that would be necessary to achieve this goal. So one of the issues was progression of mental health problems and transition points. And we here included across the life course because things that may happen in later life may also tell us a lot more about what we should be doing in earlier life. We thought about how the research would be improve promotion, prevention, treatment and support in children and young people, and particularly about the implementation of effective interventions to treat these persistent mental health problems and what would be needed in order to provide those treatments. Of course, the reason I've given you this one is because during the pandemic, the mental health difficulties of young people became a clear target for, a clear target and rose to the public's view that they now realize that these were difficulties and people talked about them a lot, particularly because of the lockdown and the reduced educational opportunities and social opportunities that produced. So it's okay to produce goals and targets, but we also need measures. And there's 2 reasons for this. We need to know whether we've achieved what we wanted to do in the goal. but also it's important for continuing to raise awareness. So every 5, 10 or 20 years, you need to remind people and evaluate where we are, because that will give you the potential for switching investment. So just using that one goal, so research to halve the number of people with young people with persistent mental health problems. Well, we have an Office of National Statistics which enables us to measure exactly that. This is age 5 to 19. Most of and there is an incremental change over time. So there's more mental health difficulties in the 16 to 19-year-old group, particularly in young women. Whereas earlier there are fewer mental health problems, but also it's more likely to appear in boys. So that was measured in 2018, so that's 1 in 8. In 2020, it was 1 in 6. And as you can see, it's now changed to 5 to 16-year-olds. So cutting out that top group, which actually had more difficulties. So we can show that that over the pandemic, we have increased the number of kids with mental health problems, made it potentially more problematic for us to achieve our goal. But we do have now a way of measuring whether we have achieved that. So politicians were involved in this, and I can just tell you a sort of anecdote. I was sitting on holiday in Scotland in the car on a teleconference with Chris Whitty and the rest of the group, thinking about how we reduce, or agreeing finally, the communication system and the number of goals we were going to have. And it had been argued with the Secretary of State that we could only have 2 goals. We had to choose which 2 goals they should be. While I was sitting there, this was outside a whiskey distillery, and all my family were in there doing the whiskey tour. I was sitting outside in the car. That was at 3:30 in the afternoon. We agreed the comms program. And then at 5 o'clock, the Secretary of State moved from being the Secretary of State for Health to the Secretary of State for the Foreign Office. So this whole program of research came to a complete halt because the person that we had got to drive it had moved. So we all kind of chased our tails for a bit because we'd taken a long time to choose which 2 goals we were going to have, and but pulled ourselves together. And in 2021, we published the final goals. So research to halve the number of persistent mental health problems in children. This is a big one. To eliminate the mortality gap. That is a stretched target. And we had a lot of arguments about that. To develop new and improved treatments and improve choice and access to healthcare. You can see here the one word that's moved is quality, and that was because we had a few more goals that we had, but we had decided that we had to focus on fewer, and that improved choice might change to differences in quality that have been achieved in these different support systems. You'll notice that we say mental health care treatment and support in hospital and community settings, because the support was a particular issue that people with mental health, who with lived experience, said they wanted. Okay, so has it had an effect? Well, in June this year, we got 24 million invested into adolescent mental health in these sorts of topics. In digital, in student well-being and mental health, in eating disorders, one of those areas that didn't get much money, adverse childhood experiences, resilience, and mechanisms for unsuccessful transitions for care experienced young people. So we have already had an impact, but you can't imagine that you need to stop there. You definitely can't stop there. You've got to keep going. So what you need to develop a roadmap for research is have goals that are accepted by all stakeholders. You need to continue, so don't just leave it there, continue to highlight them at every opportunity. So that's with policymakers, talks. I've given one recently to clinicians across the country. You need to keep thinking of press stories. So I'm on the list for the Science Media Centre, and I've raised money so that they have a particular person at the Science Media Centre, which I think you have in Australia as well, whose focuses specifically on mental health. And you need to hassle the research funders and just say, well, where is the data? What are you doing? And that is, and I've done it both in person and on the radio and TV, saying, they need to step up. But also the research funders do want to do that, but it's quite difficult for them to argue for those sorts of strategies when there's lots of other strategies, like at the moment, issues about infectious disease. So you need to get involved where the money is, particularly in government and with policymakers. But you need to understand, and that's the issue that I thought was really important for you to understand in terms of when you do get involved with them, you can come a cropper, because politicians don't stay in one place for very long. And we certainly worked really hard with the one important minister, only to discover that we should have published the document a month before. But even then, anybody new coming into post will not be that interested in something that their predecessor actually produced. I've come to the end. So this is some, but not all, of the people involved in the Roma project, but I wanted to just highlight these people, Stefano, Carla, and Josep Maria. Without them, my energy would have depleted quite quickly. You need a lot of friends when you're producing these things. But I also wanted to highlight all these people who really push me along, and they're academics, they're policy people, and they're individuals with mental health, lived experience of mental health services. And of course, this person who was really important in just guiding us and understanding the politics of all of this. I'm hoping that we will be able to continue to have impact, but it will take all our energy, and you get that by having a good group of people who work together to support each other in these ventures and to share the responsibilities for this across a whole group. Okay, thank you very much.